Bonjour. Merci. Merci. Oh, thank you very much, Damien, for inviting me here. I feel honored, and I look forward to having exchange with you on this topic. And yes, we have met. I think first time was it at European Medicines Agency. At least I think we share a common interest in drug development more generally, and that's my specific interest has been on anticoagulation. So the evolution of anticoagulation in specifically for children in general and for pediatric cardiac disease specifically has actually already started over the last 10, 15 years. And so I will cover what's been going on for that time and how far we have come now. Then I will also give you some perspective of future options for children. Yeah. Some disclosures. This is really just to show that we, in this area of drug development, we need to work with industry. And I've been working both on the side of the regulatory authorities as well as with industry. And I think it's important that we as academians work together and be proactive in guiding industry to develop medications also for children. Just some context, as Damien has already started, thromboembolism in pediatric heart disease is a frequent complication, and we have a number of pathophysiological factors contributing to that, like the alteration in hemodynamics, intravascular catheters, prosthetic materials, surgery, obviously, and bypass as such. There are certain high-risk groups, children. Almost all these children need central lines in their vessels, shunt dependent, single ventricle, Fontan circuit, obviously, children with Kawasaki disease, coronary aneurysm, and cardiomyopathy. Thromboembolic complications cause a significant morbidity and mortality in our children. To just exemplify that from one study done a while ago, or a summary of data, clinical data from the Hospital for Sick Children in Canada, who showed that about 11% of their children receiving surgery for cardiac defects had traumatic complications. And the risk groups most severely affected were the youngest infants, were children with cyanotic heart disease, heart transplantation, or children with VAD, for example. This is why we use anticoagulants in children in general, but specifically in cardiac children, for preventing clots and for treating them when they occur. And I list here some of the indications, specific indications where we use them, which does not necessarily imply that these indications have definitely been proven to need anticoagulants. Some of it is extrapolated from adults. Some of it is empirical, but we know that particularly when we look at cardiac indications, these children are at high enough risk that we have been using anticoagulants for quite a while, and we would not dare not to use that. We use the anticoagulants available that have been available for a while, and this graph just summarizes the types of anticoagulants that are currently available. The blue ones, indicated in blue, are the classical anticoagulants, the vitamin K antagonists, who really interact or decrease many of the coagulation factors in the coagulation cascade, thereby kind of limit clotting. The heparins having a more specific effect on factor 10 or factor 2, so towards the end of the coagulation cascade. And then in orange, the newer direct but parenteral anticoagulants, which I won't cover in much detail, and in red, the direct oral anticoagulants, which will be more a focus of my talk. Coming back briefly to the classical anticoagulants that we are still using and have been using for a while, they have a number of practical limitations for their use, particularly in children. We don't have age-appropriate specific formulations for children, so there's the danger of dosing calculation errors and wrong dosing. We don't want to use parenteral anticoagulants in all children. We need them obviously for acute situations. We have unpredictable PK pharmacokinetics, particularly for the unfractionated heparin, which probably is used most commonly in children with cardiac disease. we have the problem that the heparins are dependent on antithrombin, which can frequently be low physiologically as well as due to the disease. Vitamin K antagonists, you all know, are very difficult to handle, even in the chronic setting, because of dietary and drug interactions. All this means that we need to frequently monitor children with the classical anticoagulants, which means a lot of efforts and logistics, but also is not very well accepted by children. And there are no licensing studies for any of these drugs. Yes, in the US, one of the low molecular weight heparins has been licensed for just a few years ago based on very poor, very little data. And on the other hand, the newer direct oral anticoagulants that have been licensed in adults for about 15 years ago. And here the pharmacological properties, in summary, are not too far different from the low molecular weight heparins, with some variations between the different DOACs that I'm listing here, dabigatran, rivaroxaban, apixaban, edoxaban. But essentially, they are not too far different with once to twice daily dosing, but they have a number of advantages. One, they are oral, which in many cases is appreciated by children, as you can imagine. They work directly in the coagulation system. They are not dependent on the endogenous cofactors such as antithrombin. And finally, because the pharmacokinetics are much more stable, they have been tested and are being used and are licensed to be used in the fixed dose regimes with no monitoring for adults in the past. And as I will show you, the same is true for children. Given that we now have regulatory requirements for pharmaceutical companies to study their medications also in children, we were lucky enough that for the time when the DOACs became available for adults, companies needed to study them also in children. So this table shows the pediatric investigation plans for all these DOACs that I listed before for children and the specific indications that were targeted. So mostly for prevention and cardiac diseases were quite prevalent here for the reasons that stated that here we really have a problem, and a number of these investigation plans also targeted the treatment of acute, already present thrombotic events. I'll pinpoint a few of these studies, or actually it's more than one study, developments, but for time reason I can't really go through all these studies. I'd like to start with the rivaroxaban studies just on VTE treatment, or treatment of venous thromboembolism, just to give you an example that developing a drug for pediatric use is not just doing a single study. It's really a stage development going from, first of all, developing a pediatric, specific, age-appropriate formulation, in this case, an oral suspension, so a syrup, then modeling adult data for pharmacokinetics, the dosing data from adults in combination with physiological data on pharmacology in children, these so-called physiologically based PK models to predict doses in children, then only going into phase 1, in this case, phase 1, phase 2, and the phase 3 study to first try out, modify and adapt the doses, and then eventually in the phase 3 study to validate the dose regimes based on clinical outcomes. So this was quite a huge program, and I can't show you any of the results of the specific studies, but would like to move on to actually summarize the the pediatric trials on treatment in this case of venous thromboembolism that have been performed for regulatory purposes. So that's the Einstein study, the phase 3 study that I just showed you, the one on dabigatran, the diversity study. There was another small scale academic study that also provided a randomized comparison. So what do we see when we evaluate anticoagulants? It's about preventing, in this case, patients already having had a clot, preventing recurrent clot. So the efficacy is seen by how much recurrent clots occur. And what we can see in this meta-analysis, each of these studies showed at least the DOAC to be as good as classical anticoagulants. The comparison here was either vitamin K antagonists or heparins. But in summary, you could even see a slight advantage of using the DOACs as compared to standard of care. For bleeding, major bleeding, again, a tendency for an advantage, but not not significant. And with regards to general bleeding, at least you could say it's equal, but the tendency, probably we could discuss this at length, is maybe with little more bleeding of not so much severity. So that's a summary of treatment studies. I want to move on to preventive studies, many of which have been performed in the cardiac setting, and I'm sure some of these studies are known to you, or some of you have participated in these studies. One is the UNIVERSE study comparing rivaroxaban versus aspirin in children after Fontan surgery. It's a rather small-scale study, limited to the age range where Fontans are being done, obviously short after Fontan procedure. And these were children who didn't have any evidence of prior thrombosis. So this was on primary prophylaxis. The design was, I can't go into much details, but in this specific development, the pharmacokinetic assessment based on a prior modeling, again, was actually in a pre-phase of that study, and then there was randomization for up to 1 year comparing rivaroxaban versus aspirin. I'll come back to the results of that study later on. Edoxaban, again, another of these DOACs compared to standard of care for children with cardiac disease, slightly larger study of all pediatric ages, rather small proportion in the youngest age group, children with any kind of cardiac disease at risk of thromboembolism, who required longer-term anticoagulant prophylaxis. Here, I just already inserted a breakdown of children. Again, Fontan is quite a big proportion, and some a smaller proportion with Kawasaki, and some other various indications. Here, it was a comparison between edoxaban versus standard of care, but in the long term, in an extension, that was only for 3 months. In a long-term extension, children were observed on edoxaban for up to 1 year. And finally, the third study done for apixaban for regulatory purposes, again, prevention. So children with cardiac disease between 1 month and 18 years requiring thromboprophylaxis were randomized to apixaban versus standard of care. This study was, again, slightly bigger, quite similar age breakdown to the other groups, and single ventricles here were the largest proportion. And we don't have time enough to go through all the details of the results, but again, from a meta-analysis of these studies done for cardiac patients, you can see here it's about prophylaxis, so it's not recurrent, but how many thrombotic events did occur. So for efficacy, we can say that there, for all 3 studies, actually, one study didn't even observe any thrombotic events with neither the DOAC, neither apixaban, nor standard of care. But for the others, the few thrombotic events indicate a tendency to the DOAC being potentially even better, but not significantly. With regards to bleeding, we don't see much differences, so we can say the DOACs were equivalent, at least, to standard of care, with obviously a lot of convenient factors with regards to administration, as well as no need for monitoring. And just to give you, and this is a more complicated table, I tried to summarize all the DOAC trials that so far have been performed and published, again, on the 4 different types of DOACs. I have briefly summarized or shown the diversity study for treatment of acute VTE, the Einstein for treatment of acute. So these were the treatment studies using, as these patients had fresh thrombus, high-intensity anticoagulation. And then the prevention studies for rivaroxaban, edoxaban, and apixaban. The UNIVERSE study, actually, I didn't mention that earlier, using low-dose, low-intensity anticoagulation because it was comparing to aspirin. The others, high-intensity, as would be used for adults with, for example, atrial fibrillation. Then there was another study that I didn't mention because was not done in cardiac disease, but in leukemia using apixaban in low intensity compared to no anticoagulation. So asking the proof of concept, do we actually need anticoagulation in that specific high-risk setting of leukemia? I don't go into the details of our outcome events again. I really just wanted to use that table to show you again that for all these compounds, the studies have been completed. An important practical consequence of these developments and the phase 3 studies that have shown us efficacy and safety is that we now have pediatric dose regimens for these compounds, which are really specific for all different, in this case, weight groups rather than age groups, but down to, as in the case of rivaroxaban, down to neonatal age. As I mentioned, we have these studies done on treatment of acute VTE, which also went up to secondary prevention of up to 12 months, so using the drug in a longer term. And we have these thromboprophylaxis studies done on lower intensity on the adult dose of 10 milligrams, so the prophylactic dose in adults, equivalent in different weight groups. What's also very important is that that part of these developments, age-appropriate formulations have been generated, that I've mentioned the suspension generated for rivaroxaban that is really very flexible, can be used between neonatal age up to 30 kilos, so up to late primary school age. I won't go through all the dose regimes, but apixaban is interesting as well because they have covered quite a number of different indications. Since about half a year, apixaban is licensed for children in Europe by EMA. Interestingly, for the indication of treatment of acute thrombosis, in spite of the fact that that study has not yet been published, it has been ongoing until quite recently. But as you can see, it's like the adult dose used for treatment of acute VTE, which is increased in the initial phase of 1 week, and then continues with half the dose. And these same doses have been used as well in the saxophone study that I mentioned for primary and secondary prophylaxis, in spite of the fact that this license does not include primary prophylaxis, neither in the high intensity dose nor in the low intensity dose that has been used for the leukemia study. So interestingly, we have again another drug indicated for treatment, but not for thromboprophylaxis. Nevertheless, I think we have very well established dosing regimes that we as clinicians and specifically cardiologists can probably quite flexibly and individually use depending on the risk of thrombosis considered for our individual patient. A disadvantage is that in spite of the license for apixaban in Europe, we don't have any of these formulations specific for children yet on the market. And I asked the company a few months ago when they will come onto the market with that, and the response was rather unspecific. So I don't know whether they actually intend to make it available eventually for children, which clearly is a disadvantage. This brings me to the last study I want to quote, which is the study from Boston Children's. Again, Boston in the room here, on real-world use of apixaban, which has been actually, the authors, Justina van der Ploem and others, have studied children up to more than 200 children over the last few years in parallel to the regulatory studies, because many of the patients who needed anticoagulation did not specifically make it into the trials that were ongoing at the same time, neither the saxophone study nor the VTE treatment study for apixaban, for many reasons, exclusion criteria and so on, and logistic reasons. So this study actually provides interesting real-world complementary data to the recent regulatory studies. As you can see, a wide age spectrum of children with cardiac disease and with single and two ventricles, and used both for thromboprophylaxis in the majority as well as treatment. For that study, for lack of pediatric commercial apixaban formulations. They just use the adult tablets, the smallest being 2.5 milligrams. So the dose regimes that they choose had to be adapted slightly based on the availability of that tablet. But so they were not exactly the same as used in the clinical studies and now licensed. But given that we still don't have these formulations on the market, we probably have to do with the tablets and breaking them up as well. And just briefly, the clinical outcome was quite consistent with what we have seen from the clinical trials. Yes, we see some bleeding, particularly in these very sick children around surgery, but it was not very frequent. And the efficacy data obviously were not very strong in this observational study, but they report that they have seen improvement of thrombosis in patients who had follow-up imaging. So concluding on the status quo of these recent development of anticoagulants for children, we can say that dabigatran, rivaroxaban, apixaban are actually licensed for treatment of VTE and secondary prevention in the longer term for such events. Rivaroxaban is also licensed for thromboprophylaxis after Fontan, as I've shown you, based on the university. Interestingly, only in the US, EMA has not taken up that indication. Edoxaban and apixaban have been studied for prevention in cardiac disease, as I've shown you in these studies. Apixaban also in leukemia. I think as I mentioned, one of the key advantages that we really have solid dosing data now for almost all pediatric age groups. We have pediatric formulations available and on the market for rivaroxaban and dabigatran, with the limitation that dabigatran is probably, as far as I know, not available in many countries, including the US, the formulations. Overall, the results show that the bleeding risk with these drugs is relatively low, and the efficacy is at least comparable to standard of care anticoagulants. However, based on quite limited sample sizes, many of these pivotal trials were really not powered to show us definitive results, and in somewhat selected populations, as young children, infants, and particularly neonates were underrepresented. We have some real-life pediatric experience with DOACs evolving. I've just shown you one of these studies that mostly confirmed the results from the clinical trials. In my understanding, we still have a number of open questions. This was too fast. That I don't think I'll go into any details, but I think one of the limitations is really data from neonates. We have no data at all from preterms at the moment. Do we need initial parenteral anticoagulation? We have some information on anticoagulant intensity and different dose regimes for that, but when to use which intensity still is open. Can we reduce it in the long term and so on? So there are many questions that we still need to address in the clinical setting, in real life studies. But I also want to give you a perspective. There's a new generation of anticoagulants already being studied in adults for quite some while now. Actually, the factor 11 or factor 12 inhibitors. When I showed the initial cartoon of the coagulation cascade, I left out the factors 11 and 12, who don't usually have a big important role in initiating coagulation when we want to stop bleeding, but they apparently have a role in with regards to development of thrombosis. And it has been shown that if you, there are good data, even preclinical data, when these factors are limited or inhibited, that thrombosis can be prevented well with less risk of bleeding, at least in vitro and in animal studies, than compared to the standard anticoagulants and the DOACs. So the promise of these drugs might be that, particularly in the high-risk situations that we have, again, very typically in children and in children with cardiac disease, consider VAT patients who really are at risk of thrombosis as well as bleeding, where that these might be even more applicable and have a better risk profile. Various mechanisms of inhibiting here factor 11 and a lot of adult studies ongoing in the typical adults indications, initially starting with orthopedic surgery and prevention of thrombosis, cancer-associated thrombosis, atrial fibrillation, but also stroke. Some of these developments have reached phase 3, and I can just tell you that companies are preparing pediatric investigation plans for these new drugs as well. This is in the early days. One of these studies is supposed to have started in phase 1 in children, but this will be for the future. And it will be interesting next 10 years to get these drugs potentially in the clinical practice. Thank you.